Dear doctors, arterial blood gas interpretation is one of the most important and often one of the most intimidating skills for junior doctors and critical care trainees. In emergencies, ABG can reveal life threatening problems within seconds: respiratory failure, severe metabolic disturbances, mixed acid base disorders, and hidden physiological collapse. But the good news is that ABG interpretation does not have to be complicated. If you follow a structured, stepwise approach, every blood gas begins to tell a story. In this video, we will go through real case and learn how to systematically analyze arterial blood gases, identify compensation, recognize mixed disorders, and avoid common mistakes that can be dangerous in critically ill patients.
Clinical scenario. A 68-year-old man with diabetes, chronic kidney disease, and severe pneumonia is admitted to ICU with septic shock. Respiratory rate, 32 per minute, BP, 82 by 48 millimeters of mercury, heart rate, 128 per minute, SpO2, 90% on 15-liter oxygen, temperature, 39.2 degrees centigrade. Arterial blood gas. pH, 7.12, PaCO2, 58 millimeters of mercury, HO3, 18 millimole per liter, partial pressure of arterial O2, 62 millimeters of mercury, lactate, 7.2 millimole per liter. Stepwise interpretation. Step 1. Is the blood acidic or alkalotic? pH 7.12 denotes severe acidemia. So this patient is severely acidotic. Step 2. Which component explains the low pH? Respiratory or metabolic? In this patient, PaCO2 is elevated means respiratory acidosis. HCO3 is low means metabolic acidosis. So, both metabolic and respiratory abnormalities are present and contributing to acidosis. Therefore, this is mixed metabolic and respiratory acidosis. Step 3. Is compensation appropriate? For metabolic acidosis, expected respiratory compensation can be estimated using Winter's formula. Bicarbonate is 18. Then expected PaCO2 according to Winter's formula should be is almost equal to 35 plus or minus 2 millimeters of mercury. In this patient, actual PaCO2 is 58 millimeters of mercury. That means the patient is retaining far more CO2 than expected. Therefore, metabolic acidosis is present and a superimposed respiratory acidosis exists. Step 4. Determine likely causes. In this patient, metabolic acidosis is likely due to lactic acidosis from septic shock and hypoperfusion. Respiratory acidosis is likely ventilatory failure due to fatigue and denotes impending respiratory collapse. But what about oxygen status? Though arterial partial pressure of oxygen is 62 millimeters of mercury, which in itself is sufficient to maintain oxygenation. But considering the fact that this value is on 15 liter of oxygen means this patient is severely hypoxic, hence requiring oxygen to maintain adequate oxygenation. So what is final diagnosis? It is mixed metabolic and respiratory acidosis due to septic lactic acidosis, as lactate is high with acute ventilatory failure. There may be metabolic acidosis component from chronic kidney disease as well. Additionally, there is severe hypoxia due to severe pneumonia.